For decades, treating PTSD has felt, well, a lot like trying to empty the ocean with a teaspoon. The standard tools we've relied on often just manage the symptoms without ever really reaching the deep root of the trauma. But today, two radically different substances are making headlines and offering some very real hope. Welcome to this explainer. Today, we are diving deep into the neuroscience of MDMA and ketamine. We're going to unpack two substances that could literally not be more different, yet both are aimed at healing the exact same thing, the traumatized brain. We're going to explore exactly how they work, what the clinical data actually says, and why the current medical landscape surrounding them is so incredibly complex right now. To really understand why this topic is sending absolute shockwaves through the psychiatric community, you just need to look at one number: 67%. That is the astounding percentage of MDMA group participants who no longer met the clinical criteria for PTSD at 18 weeks in the Phase 3 MAP1 trial. Now put that into perspective. In traditional psychiatry, treating chronic PTSD with standard SSRIs usually results in modest symptom reduction at best. Many patients just kind of learn to live with a blunted version of their trauma. But a 67% total remission rate, that doesn't just represent some tiny incremental improvement, it is a massive paradigm shift in trauma care. But here's the fascinating part. While MDMA opens the heart to enable deep therapy, ketamine numbs and disassociates. We're talking about two fundamentally different paths to the exact same destination. Think of MDMA like opening a heavily guarded locked door so you can finally go in and clean out a profoundly messy room. It's a heart-opening empathogen, but it requires intensive, structured psychotherapy to guide that cleaning process. Ketamine, on the other hand, it's more like rebooting a frozen computer. It's a dissociative anesthetic delivered by an IV infusion in mere minutes, and it bypasses that emotional processing entirely to force a hard system reset.
Okay, so here's our roadmap for today. First, we'll look at their opposite brain mechanisms. Second, therapy versus rapid infusions. Third, we'll put the trial evidence head-to-head. Fourth, we'll cover their FDA status and safety. And finally, we'll ask, which fits whom? Let's break down the science and the data. Starting with Section 1, opposite brain mechanisms, a serotonin flood versus a glutamate surge. It is genuinely wild that two treatments targeting the exact same debilitating condition operate on completely different neurological highways. They don't just feel different, they rewrite the brain's chemistry in diametrically opposed ways.
So, MDMA's logic is entirely psychological. It works by reversing the serotonin transporter, which floods the brain with a massive wave of serotonin and oxytocin. But what does it actually mean for the person experiencing it? Essentially, it turns off the brain's fire alarm. By reversing this transporter, MDMA directly dampens the amygdala, the brain's primitive fear center. It creates this overwhelming feeling of profound safety and trust. And that's crucial because it allows patients to mentally revisit their most horrific traumatic memories without triggering the absolute panic that usually stops them from processing the event. It essentially reopens a critical period for social reward learning.
Now, ketamine works on the complete other side of the spectrum. It is directly neuroplastic. See, chronic stress and severe trauma literally physically erode the dendrites, the little branch-like connections in the prefrontal cortex. Think of it like a garden that's just withering away. Ketamine blocks the NMDA receptor, which triggers a massive glutamate surge. Going back to our garden analogy, this glutamate surge acts like a super powerful fertilizer for the brain, rapidly regrowing those eroded synaptic connections in a matter of hours. It doesn't rely on psychologically processing the trauma, it relies on rapidly rebuilding the physical hardware of the brain itself.
So it helps to think of this as a software versus hardware approach. MDMA targets the psychological software. It uses that serotonin and oxytocin flood to open the patient up for intense trauma work, relying on the psychological experience to drive the healing. Ketamine, though, targets the physiological hardware. It uses a glutamate surge to neuroplastically rebuild synapses, relying on a rapid biological reset. They aren't just interchangeable tools, they represent two entirely different theories of how a traumatized brain might heal itself.
Moving to Section 2, therapy versus rapid infusions. Two very different treatment models. The crucial point we have to make here is that these opposite mechanisms dictate entirely different treatment architectures. You simply cannot separate the drug from the way it's delivered. The MDMA model is highly psychotherapy-centric. It explicitly uses the drug as a catalyst inside a highly structured, manualized two-therapist program. This involves an immense amount of human connection. We're talking about extensive preparation sessions, followed by 2 to 3 dosing sessions that take up most of a day. The patient might wear eye shades, listen to a curated music playlist, and literally hold a therapist's hand through the hardest, darkest moments. And all of this is wrapped up in extensive integration therapy afterward.
The drug is completely inseparable from its psychological scaffolding. Conversely, ketamine relies on a medical, drug-centric model. A standard protocol might involve 6 intravenous infusions over 2 weeks, often with minimal or even zero structured psychotherapy. Because it's highly medical and requires less specialized psychotherapy training, it is vastly more scalable and much faster to access. I mean, this totally explains the massive real-world boom of ketamine clinics we've seen popping up lately. But because it often lacks that structured therapy, patients are getting a powerful neuroplastic stimulus without the guided therapeutic context that helps consolidate lasting behavioral change.
Let's look at Section 3, Trial Evidence Head-to-Head. How do these different models actually perform when we look at the clinical data side by side?
Okay, in an unbelievable coincidence of data, both MDMA and initial ketamine treatments hit the exact same number. MDMA showed massive, durable effect sizes with 67% and then 71% of participants losing their PTSD diagnosis at 18 weeks across 2 major trials. On the flip side, ketamine matched that 67% in initial rapid response rates. So in terms of sheer numbers, both show an absolutely undeniable ability to disrupt PTSD symptoms compared to a placebo. They both work, and they work incredibly well in the short term.
But here's the catch with ketamine. Its relief is often transient, fading after a median of just 27.5 days without further dosing. Think about the emotional roller coaster for a patient here. You experience this profound relief from debilitating trauma symptoms, only to feel them creeping back in less than a month. While MDMA's gains were largely sustained out to the 18-week endpoint and beyond, because the root trauma was actually processed, ketamine recipients often find themselves needing chronic, ongoing maintenance dosing just to keep the symptoms at bay.
Section 4, FDA Status and Safety. The regulatory reality in 2026. Because despite these incredibly compelling numbers from clinical trials, the path to the clinic is definitely not straightforward. The reality is, neither of these drugs is actually FDA approved for PTSD as of 2026. MDMA received a complete response letter from the FDA back in August 2024 requesting another trial. A major sticking point for them was what's called functional unblinding. Basically, functional unblinding means it is practically impossible to hide from a patient, or a therapist for that matter, that they've just taken a massive dose of MDMA, which can heavily inflate expectancy effects. Meanwhile, no form of ketamine is approved for PTSD either. The nasal spray Spravato is approved strictly for depression, which makes the widespread use of ketamine for PTSD entirely off-label.
And their safety profiles also totally different. Because MDMA is administered only a few times in a highly controlled setting, its acute physiological risks, things like blood pressure spikes, acute hyperthermia, or dangerously low sodium, are managed directly on the spot by medical professionals. Ketamine, however, carries insidious cumulative risks. Repeated dosing over time can lead to ketamine-induced cystitis, which is a severe and incredibly painful form of bladder damage. Plus, there is genuine abuse potential and dependence to consider, since ketamine is a Schedule III controlled substance.
Which brings us to our final section. Which fits whom? With such contrasting approaches, one psychological and one physiological, one durable and one transient, how do we actually determine which treatment fits which patient?
Well, the data strongly points to 2 very different clinical roles. If a patient is facing an acute crisis, severe suicidality, or massive depression, ketamine's sheer speed is an incredible life-saving tool. It provides rapid relief when time is quite literally of the essence. But if a patient is looking for long-term resolution, and they actually have the emotional capacity, the time, and the resources to undergo an intensive psychotherapy course, MDMA-assisted therapy points toward a much more durable, permanent processing of the root cause trauma.
I do want to take a quick second to emphasize that navigating trauma is deeply, deeply personal. This explainer is strictly for educational purposes, not medical advice. Treatment decisions must always be made with a qualified clinician. The landscape of a patient's history, their comorbidities, the urgency of their crisis, and their access to care is incredibly complex. Because neither approach is fully approved for PTSD yet, we are quite literally standing at a crossroads in psychiatric history. So what do you think? Will the future of healing trauma look like a pill and a highly scalable IV drip, rapidly rewiring our synaptic networks? Or will it demand the intense interpersonal embrace of deep human connection and deep therapy? That is the question that's going to define the next decade of neuroscience. Thank you so much for joining me for this explainer, and keep learning.